Okay, so welcome everyone. Just a few things before we get started, okay? If people could stay muted, almost everyone is, but I'll mention it anyway, while I'm doing most of the talking. However, if you have a question, feel free to unmute yourself, okay? And if it gets too chaotic, we'll figure out something else. I have another email set up, but I do like it when people ask questions in the middle, which is absolutely fine. The downside is that sometimes I lose track of where I am and I need to be put back on course, but I've asked some people to help me, and anyone is welcome to help me with that, okay? And if my phone rings, which reminds me, I'm putting this on Do Not Disturb, I might get confused as well. But let's hope none of that happens. Let's see. Okay. So thank you all for coming. It's nice how many of you I can see. Anyone who wants to turn on their camera and hasn't is welcome to, and nobody is required to. And what I'm going to be talking about today is a concept that I've been trying to think about: different curative experiences in psychoanalysis and psychotherapy. Just before we begin, I make no distinction at all between psychoanalysis and psychotherapy. So what I'm talking about has nothing to do with how frequently the patient comes, whether or not they use the couch, whether or not they use first names or last names, or any of that stuff, okay? Because for me, the essence of psychoanalysis is, are you basing your interventions in any way, shape, or form on the transference? Now, I will come back to that a few times, but again, the technical issues about what the differences are don't matter. So I'd like to start with, and you'll find that I do this a lot, I like to start by going over some very basic concepts that many of you will know by heart and will be completely familiar, but I'd like to tell you how I'm using them, because I like concepts to fit together, and I like to have concepts put out in pragmatic ways. Somebody who is reviewing my book said, this is psychoanalysis that you can take home and use yourself at home. And that's how I like to think of it. Very usable psychoanalytic concepts to help you try to remember what it is you're doing amidst this very complicated morass of a very simple relationship. So let me start with a pragmatic definition of how I view the target of psychoanalytic therapy, which is that what we are really working on, and what is relatively distinct in this, is loosening internalized repetitions. Repetitions are frozen emotional moments in which people are acting, reacting, feeling, perceiving, or behaving in ways that were set in the past and that have outlasted changes in the external world. So that people's problems, to the extent that they are related to repetitions, are related to the fact that part of them is living in the past, which leaves them incapable of experiencing the present as accurately as they might, and stops them from being able to realize their consciously chosen goals in the present. Why? Because they're living in the past. So this is not to say that all people's emotional problems are rooted in repetitions, and it doesn't mean that changing repetitions is going to get everything you want in life. All it means is that when you are less under the influence of a repetition, that you are more able to achieve your consciously chosen goals in the present, whatever those goals happen to be, whether they mean conforming to the world around you, like every single pea in the pod, whether it means carving out a completely individualized path, whether it means working toward revolution, or whether it means doing exactly what your parents did and you don't want to do anything different. Whatever you choose your goals to be, you will be able to do them more fully if you are freed
Stop
from
it,
the
Jesus
influence of
Christ!
the
Look at
past.
this. Why does it keep doing? Why does it keep popping up like that?
I'm sorry.
Thank you.
Okay. Okay.
Let me use, can you just?
Okay. Anyway.
Oh my God. I'll never, because look, I'm going, where is it? I haven't tried to use it. Where is it?
Okay. Okay. Anyway, sorry about that. Okay. So we are trying to change repetitions. Okay. And again, I just want to emphasize before we go on, it is completely incompatible with any kind of normative goal. None of these curative experiences.
Why are you moving it and I'm trying to move it?
Jim, Jim, could you mute yourself? Yeah, thanks. Okay. Okay. Zoom is complicated. Okay, so it is incompatible with any normative goal. And by that, I mean, whatever your theory is of cure, you know, you should resolve your Oedipal complex, you should resolve your depressive position, you should feel all your feelings. Those are all fine partial goals, but we are in the business of trying to help people loosen the effect of the past on the present. And any of those things might be involved in reaching your goals. But my whole purpose here is to say, try not to have goals and try not to be shackled to any particular way of accomplishing them. Because reaching these goals, as I say, can mean all kinds of things. Okay, you can have a stronger ego. You can know your effect on other people. You can be reparented. You can make your unconscious conscious. Where there was id, there shall ego be. You can develop a personal narrative of your own life story. You can mentalize, you can feel all your feelings. Every school privileges certain kinds of things that may happen in the course of analysis. And all of those things will help some people some of the time. What I've tried to tease out here, though, is that for me, I sense there are basically three types of major experiences.
Oh, he's recording it.
Okay.
He's recording it. So maybe that has something to do with why you can't hear it? I want to get out of it.
Jim,
I want to get out of it.
Okay. Hold on. Sorry. Jim.
Oh, I wonder if.
Jim. Yeah. Okay. 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 Sorry, got a little thrown off here. Three types of experiences that engage the patient differently, that function differently in the process of, I'm going to call it cure, but we're not really dealing with cure. When I say we're going to modify repetitions, we're loosening them. Nobody gets rid of them completely. What we do is we loosen them so that people have a little bit more room to move. It's a much more modest goal. It's a much more realistic goal. And also, all repetitions have to do is be loosened. It's a little bit like getting out of a New York parking spot, okay? If you've got 1 extra inch, you can get out. If you don't have that extra inch, you're locked in. You don't actually need to change a whole lot to change your life. What you need is some breathing space, some movement so that you can make different choices and have different effects on people at critical moments. And that's enough to do it. And that's hard enough, okay? So although different schools have privileged different elements of cure, I think most of them can come down to these 3 basic types of experiences. And I want to emphasize again before we start, I'm saying there's 3. There may be more. My goal is not to limit anything, but as I discuss these experiences, I'm going to discuss them in their purest forms so that we can see that they're independent of each other, that they really function differently. You may and you will choose to combine these experiences. It is not that we're trying to say, only do it this way, only do it that way, but it's more in the lines of, if one particular way is working, that's fine. You don't need to change it into something else, okay? Now, these 3 experiences I'm going to describe as, and these are traditional things: insight and self-understanding, emotional communication, and verbalization. So let's start with insight and understanding. And this, of course, was the original view of the action, the therapeutic action of psychoanalysis. What would happen? There was unconscious feelings, there were unconscious memories, there were unconscious defenses. And when they were made conscious, the patient experienced a greater degree of self-control. Sometimes the symptoms would go down, sometimes depression would get better, sometimes they would be freed up. But the key was understanding parts of oneself that one was not previously aware of. So there were a lot of concepts that were tied up with insight and self-understanding. Okay. Now, what then is an interpretation? An interpretation is the main way that the analysts have traditionally conveyed insight and self-understanding to patients. Okay. And I'm going to give a very extreme view of what an interpretation is, a purist view, which is that it is a cognitive explanation, cognitive or intellectual explanation of some aspect of the patient's functioning to the patient for the purpose of allowing them to understand parts of themselves differently. Now, some of the lines from Freud that led to this were, his original goal was he wanted to make the unconscious conscious. And as I said earlier, he also said, where there is id, there shall ego be. And another point, he said, what do we do to accomplish this? The analyst and the patient make a compact with the patient's ego. Let's talk about the ego in a minute, to regain control of the lost provinces of the patient's mind. So this was a theory of mind in which parts, large parts of the mind were out of conscious awareness. They were affecting the patient. They were driving the patient in ways that created misery, neurotic misery, he usually called it. And that when one became conscious of it, those symptoms were relieved. So what did it? Knowledge, self-knowledge, the Socratic know thyself, the turning one's perspective on oneself so that they were able to capture parts of their experience that were previously cut off from them. Okay. When we think about this as an experience that the analyst gives to the patient, I think in its purest form, we have one adult mind, the analyst mind, communicating with the most adult part of the patient's mind. That came to be called the observing ego or the reasonable ego. But it is the most present-oriented, reality-oriented part of the patient's mind. So the analyst is communicating with that particular part of the patient's mind, the part that is the richest in cognition, the part that is the most intelligent, the part that conforms to ordinary, everyday, present-day reality. And the idea is that when that part of the mind is strengthened, it gets control over the other parts of the mind, the unconscious parts of the mind. That was called the experiencing ego at one point. I don't know why there wasn't a better term. The one that I like to use is the afflicted ego. So the afflicted ego is the part of the mind that lives in the repetition, that lives in the logic of the past, in the perceptions of the past, and functions according to those rules. So the concept of interpretation then is that when you have intellectual knowledge about that part of your mind, you are able to control it. And Freud, this was the part of his work that he was most proud of. This is where he said, this is the gold of analysis, and it's contrasted with the copper of suggestion. The copper of suggestion will fall into the category of what I'm going to call here emotional communication. But nevertheless, that was the part that he thought was the best. That was the part that he thought was most scientific and the most helpful. And he did say, however, that interpretation on its own is never enough to turn the tide against the symptom. You always needed a certain amount of an alliance with the patient, a positive non-sexualized transference, in order for the interpretation to work. So he did not emphasize that much. Most of his work was on the content of the interpretation, but the other stuff was always there. Other analysts took this in a more radical position, in a more radical direction. So for instance, the one who was probably the most influenced was Richard Sturba, and he was the one who coined the term observing ego. And he said that the function of interpretation was really to provide a new vantage point of intellectual contemplation. And he also used the term intellectual cognition. He still said you needed a little bit of positive transference to make this whole thing work, but it really catalyzed the view that what helps us here, what is genuinely curative, is making the ego smarter about the parts of itself that it can't see, the id and the parts of the ego that are unconscious. And this eventually turned into an actual diagnostic tool, if you can imagine. So with Eisler, a very important analyst in the 50s, he basically said, interpretation is the psychoanalytic tool. If a patient can respond to an interpretation, then they are an analyzable patient. They are purely neurotic, and they can be purely analyzed, and anything else you got to do, he'd call it a parameter. And he wasn't overly snarky about it, but there was definitely the sense that the really healthy people in the world responded to interpretation, and everyone else was just a little bit fucked up, you know? It just wasn't quite right. And if you were fortunate, eventually you could respond to an interpretation. And if you weren't, it meant you did not have an intact ego. So what started off as a technique then became a diagnostic tool, and then became a hierarchy of patients. And somehow or another, the technique had hijacked the whole enterprise and turned into a new mental health class system. Now, I'm being a little snarky about this, but the fact is many people benefit from all kinds of interpretations. None of this is to say that interpretations don't work. So what do we mean in practice by an interpretation? It might mean the meaning of a symptom. Someone has a cough, and the interpretation is they are coughing to prevent themselves from saying something aggressive or sexual. Okay, so interpreting the cough is an interpretation of the defense. Identifying the aggression or the sexuality underneath it is identifying, depending, either a wish, a drive, or an impulse. Okay? Somebody spills a glass of wine on somebody else. This is interpreted as an attack, as a disguised impulse of aggression. An interpretation might tie things together from the present and the past. So the analyst's green shirt might remind the patient of a traumatic incident that happened on St. Patrick's Day, and all that's left is the green. There's a whole beautiful movie about this, Marnie, Alfred Hitchcock, where the color red becomes the symbol that ties the person's present problem to a trauma in the past. And when that trauma is understood, when the meaning of the color red is understood, the patient gets better. Not with a analyst. I think it was with Cary Grant instead, but that doesn't matter. Anyway, or an interpretation might simply be a verbal articulation of a feeling that the patient has not yet put into words. So the patient is saying something like, well, I don't know, that's something about this party that's bothering me. The interpretation might be something simple as, it sounds like it's making you anxious. Yes, it's making me anxious. Why are you getting anxious? I don't know, there's something about seeing that there's somebody there. I don't know, maybe they're old. Could it be seeing your father? Oh, yes, it's my father. So clarifying experience verbally is an interpretation too. Anything in which the analyst is giving information about the patient to the patient's observing ego qualifies as an interpretation. Now, other people would say there are other ways of actually functioning with interpretation, that you can interpret directly to the patient's unconscious. that all kinds of things can happen. And that's true. But again, I'm focusing on the purest moment because I want to emphasize that this particular experience is the experience of having one's intellect control the parts of one's mind that are out of control. Okay? Now, every school of analytic thought has their own favorite bunch of interpretations. So orthodox Freudians interpret Oedipal issues. Developmental ego psychologists interpret separation and individuation issues. Trauma-oriented analysts interpret experience in terms of dissociated trauma. Kleinians are always talking about envy, reparation, and projective identification. Self-psychologists talk about empathic failures and strivings for grandiosity. And modern analysts who claim that they don't interpret are always interpreting that patients don't want to get angry at their analysts. So all of these theories privilege certain experiences. And the amazing thing is they all work sometimes, okay? For some set of interpretations will work with some set of patients very reliably and very consistently. And God knows how many more schools of analysis there are that might generate more interpretations that would make them ever more effective. It's actually rather amazing that so many different theories of mind can generate so much good. So what does this mean? It means that interpretation, insight, and self-understanding are absolutely wonderful curative experiences when they work, but they don't always work, okay? Now, one reason they might not work is because the interpretation is wrong. It's not accurate. It's not capturing the patient's experience. So it actually doesn't strengthen the ego. But people can always make mistakes. And that's sort of not an interesting reason that interpretations don't work. Okay. A more interesting reason is that they don't affect the patient's personality. They don't affect the person's afflicted ego. And ultimately, they don't affect the patient's mind or brain in the way that they do with some other patients or at some other points in time, which is to say that the whole experience of intellectual self-understanding doesn't work with everyone. It doesn't work all the time. And it can often not work even when it feels like it's working. What does that mean? How many times have you heard your patients say, or have you said yourself, I understand what I'm doing, but it doesn't help, okay? I know that I do this over and over again. I know this came from the experience with my father. I know that, I feel angry, and when I feel angry, I get anxious and I can't control myself. All of that is very, very interesting, but it does not help me to change, okay? And this is where a patient will need a different kind of experience, one that is not based on intellectual understanding, but is based on something else. So the next one that I'd like to suggest is emotional communication. Okay? So those of you who know my work a little bit know that emotional communication is absolutely my obsession, okay? I write about it. I think about it all the time. I have split hairs about it. I've looked at it more than I've looked at anything else in my life. And it's where I have tended to look when I want to change, when I want to help people to change. But I've come to understand that it doesn't always work either. But when it does work, what is it? Okay. Okay. In emotional communication, the analyst conveys feelings that come from their own subjectivity. Now, when I say that, the origin of their feelings may be found in the relationship with the patient. They may be what I would call objective countertransference, what I have other called. But right now, talking about technique, I don't want to focus on the origin of the feeling. What matters is that the analyst has a feeling. The analyst conveys the feeling to the patient with some degree of affect, okay? Affect meaning what? Meaning the emotional feel of the feeling, not just a straight statement of I feel angry, I feel sad, but I feel angry, I feel sad, I feel happy. Something that conveys the flavor of what the patient feels. The patient feels it as a feeling. They react emotionally. This is not a communication to their intellectual mind. It is a communication to their emotional mind and is experienced as feeling. Whereas the purpose of an interpretation is to provide information to the patient about themselves, the purpose of an emotional communication is to give the patient a feeling that changes their emotional state directly and changes the repetition by changing their feeling in that moment. Okay, so it's functioning entirely differently than an interpretation is functioning. Okay. Now, emotional communication is going to take place every second of human interaction in analysis and outside of analysis. Every time two or more people are in a room together, there is emotional communication. One person is expressing feelings as explicitly or implicitly. The other person is responding and expressing feelings implicitly and explicitly. The vast majority of this emotional communication is either completely unconscious or slightly unconscious, meaning that the person can become aware of it if it's pointed out to them, but it isn't noticed and it is not deliberate. Okay, so when I talk about emotional communication and analysis, I'm talking about emotional communications that are deliberate, okay? Where the analyst is hopefully consciously communicating feelings to the patient that they are aware of. Now, again, I know, we all know, we're going to be spilling feelings all the time, okay? Some of them we can do something about, some of them we can't do anything about. And those are important elements of the analysis, but they aren't an important element of deliberate technique. There's something that the analyst has to try to be aware of. The patient may bring it to their awareness, but that's not what we're talking about. We're talking about when an analyst either deliberately conveys a feeling or would have conveyed that feeling deliberately if they had their wits about them. Okay. So let me give you a rather simple example of a difference between two types of interventions on the same problem or on the same moment. Okay. So let's say the patient is anxious about giving a presentation. Let's pretend it's a webinar, okay? So they're thinking, oh my God, I'm very scared about doing this. I'm a little bit frightened. I don't know how it's going to go. And they're talking to their analyst and they say, do you ever get anxious before giving presentations? Okay. So let's say the analyst is working in the interpretive mode. Many interpretations are possible, but I'm just generating one more or less, a reasonable sounding interpretation of this. Well, I have the feeling that when you were a child, your anxiety was not recognized or appreciated by your parents. They didn't understand it. And when you looked at your parents, you didn't see them as being enough like you in order to feel understood by them. And now when you're asking me this, you're asking me if I am like you, and if I have the same kinds of experiences that you do, a kind of mirroring experience. And if you think that I do, then you will feel stronger. And if you think that I won't, then you're liable to feel more alone. Okay. Many, many ways of doing this, but let's pick that one. A purely emotional response and a purely emotional communication might be something more like nervous. I vomit every time before I do a presentation. I get into cold sweats. I shake. I can't talk. Oh, it's horrible. It's absolutely horrible. I know just how you feel. I think probably I'm worse. The way you're talking is nothing compared to what I have to deal with. Okay. Now, again, you can do that a number of ways. I'm painting in very broad strokes here. That isn't to say that I don't actually paint in such broad strokes, but you can be a lot more subtle as well with this. But the point is, I'm conveying information, but I'm only conveying information about myself to a particular part of the patient's mind. The patient's observing ego, it hears it. It's not like the observing ego has left the room at this point. But that's not what we're talking about. We're talking to the part of the patient that is anxious, that is craving an interpersonal, relational moment in which they are with somebody who understands them, has the feeling, and resonates with their feeling in the same way. So it is not the same experience at all. I'm sorry. It's not the same experience at all. They function entirely differently. Some people will do better. Okay.
Yeah, really.
Some people,
No, I don't want it. It's just, let's not talk about the food. It's really irrelevant. Let me just.
okay. Somebody could mute themselves. I'd appreciate it. Thank you. Okay. So it's not the same experience at all. Some patients will respond to one. Some patients will respond to the other. Some patients will respond to one form of communication early in their treatment and a different part in the other. It doesn't mean that you're wrong in the content. They're both based on the same understanding of what's going on, but they're engaging the patient differently. They're engaging the repetition differently. And we have to assume that they're engaging the patient's brain differently. Okay. Sorry.
Sometimes that happens.
Okay. And they're engaging the patient's brain differently. Okay. We don't know enough about brain functioning to assign particular interventions to particular forms of brain functioning. I know that there are some very thick books by some very intelligent people who have tried to do that. I suspect we're years and decades away from doing that with any degree of certainty. But interesting as these ideas may be. But I think we can assume that when somebody has a completely different experience, their mind is engaged differently.
So I'll just go wherever you're going. I don't know what.
Let's see. So, what is the range of emotional communication? Okay, at one end of the extreme of emotional communication, there may be purely silent communications. Okay. I'm going to take an example that happens with a certain kind of depressed patient, analytic depression. A patient in which there's a tremendous feeling of despair, hopelessness, a lack of agency, and a feeling of deadness. The analyst often ends up feeling the same feeling. Okay? You and the patient can sit there for weeks or years on end feeling dead. And the analyst may say nothing about it, okay? But my sense has always been that when the analyst sits there and contains it and endures it, which is something that nobody else in the patient's life is liable to do. Most people, once they get into the patient's life, if the patient starts inducing that dead feeling in them, they say goodbye, they drink, they turn on the TV, they break up with them, they don't spend time with them because people don't want to have those feelings. But when you do that, when you have that feeling, when you endure it, my sense has always been that there is a communication, that the patient knows what you feel and feels what you feel. This could be psychoanalytic science fiction, but it seems to happen often enough so that it's probably got some accuracy to it. Now, that said, I don't think that all analysts can radiate a silent feeling sufficiently for all patients to feel it. And some patients, I think, are less sensitive to these very extreme silent communications, where the analyst just has a feeling and holds it or tolerates it. You know, Winnicott's theory of the holding environment is very much this sort of a silent emotional communication, that no matter what your feelings are, I, the analyst, will feel them and I will hold them for you. And we're sort of relying on the silent communication. On the other hand, many feelings can be expressed implicitly through tone, through prosody, through small inflections in people's voice, in rhythm, in facial expressions, if the patient is looking at you, if the patient isn't using the couch. Face is complicated because most people have a lot less control over their face than they have over their voice. So where a lot of people emphasize the importance of facial expressions, to my mind, at least because my face often feels out of control, it's a bit of a wild card. But in your voice, most people can learn how to very carefully modulate their feelings, say things with a high degree of specificity, and get a sense from the patient of how they're reacting to changes in the voice. Okay. So many times feelings will be communicated implicitly through these subtle undertones in the voice. And then sometimes feelings will be communicated explicitly. I feel this, I feel that, either about the patient or about someone else. The patient says, God, you know, that actor that I saw in that, every time I see Tom Cruise, I get a little annoyed. You get a little annoyed? I think he's enraging. What a narcissistic fuck. And the patient giggles. And you find out that by verbalizing that feeling and letting them use your feeling, they have access to that feeling themselves. That's one particular technique. Okay. Anytime you use a feeling for whatever reason, one would like it to be goal-oriented. It should be goal-oriented in the sense that, just like with an interpretation, you have some reason that you're communicating that feeling, knowing, however, that one is human, that all kinds of feelings will be communicated. You're not always going to get it right, and sometimes the results are unpredictable. Okay? But whatever it is, you're doing it deliberately. Here, we see that the relationship between interpretation and emotional communication can seem blurry. And what I mean by that is, without a way of understanding the patient, interpretation is a way of understanding the patient, you often don't know what to do. But that is different than communicating that understanding to the patient. So emotional communications do not usually convey information directly to the patient about their repetition, okay? But they are based on an understanding of that. Now, that said, a lot of emotional communication is going to be intuitive. A lot of emotional communication is going to be spontaneous. And if asked about it, much of the time you'll say, yes, that's what I would have done, again, if I had my wits about me. Now, what feelings can be communicated? At one end of the extreme, we have the modern analysts who basically think any feeling at all can be curative in the right moment with the right patient. So loving the patient can be a feeling that's curative. A lot of people, a few people these days would disagree with that, but most people are pretty comfortable with that, okay? Or some sort of, desexualized, neutralized, don't worry, we're not going to fuck love, but some sort of more human love, most people would agree with, okay? Not that fucking isn't human. I mean, the more generalized love, okay? Can't get too far without stepping in the wrong direction here. Anyway, on the other hand, moderns would say, talking with the patient, if the patient is talking about how they've enjoyed watching their feces disintegrate in the toilet, and the analyst giggles and says, yeah, that's fun. I like to do that too. Or the analyst talks about hating somebody, or the analyst talks about contempt, or silliness, or giggling, or loving to cook, or loving Antonioni, or loving Saturday morning cartoons, or hating any of the above. Any kind of feeling can be curative in the right moment with the right patient. Other schools are more limited in which feelings that they want to communicate. So for instance, Stollerow in the intersubjective school tends to focus on a very particular type of empathic communication that is very similar to Kohut's idea of empathy. and they always combine it with a particular type of interpretation. So that's the range of feeling that they feel comfortable with and that they feel is most effective. Stollerow says that's actually the only thing that works. He's not right about that, but he's certainly right that that's a very powerful combination when it works. And then the most extreme of the other end would be certain classical analysts who probably don't, it's not clear to me whether any of them are under the age of about 85 these days and whether they exist in the world, but they might, that really think that every interpretation should be done in complete emotional neutrality. It's possible that that's what the Lacanians think, but I haven't been able to really figure that out. But there's certainly certain American classical analysts who think that any degree of feeling combined with an interpretation is wrong, and they want to leave the analyst's feelings out of it altogether. So from my perspective, they have left this particular dimension of curative experience outside of their therapeutic armatorium. That doesn't mean it doesn't work. It just means that they're taking one way that one human mind can affect another human mind and leaving that out. Now, interpretation doesn't work with emotional communication doesn't work with everyone either. Again, the problem may be you didn't give them the right feelings, you didn't give them the right feelings at the right time. But I've certainly had patients where I feel like, I've done everything I possibly could emotionally. It doesn't move them. They may have been the wrong feelings, but what they needed was insight. They needed interpretation. They needed their observing ego strengthened intellectually and cognitively. That's what worked for them. Okay. Now, let's go to the third one. There is still another option, which is in some ways less interesting than the other two, but which nevertheless has its own place, and that is verbalization. So on the one hand, verbalization seems utterly banal. Okay. On the one hand, sorry, 1 second here. On the one hand, when you verbalize, that's the raw material of every therapy. What was it originally called by that first patient, Anna O? The talking cure. What did Sabina Spielren say what did Jung say to Sabina Spielren? He said, all we're going to do here is talk. Okay. What should you talk about? Freud said, say everything that comes to your mind. Spotnitz said, just say everything. Spotnitz took it further and said, if you keep the patient talking, they will get better. They have no choice. Okay. Now, some of this, again, is raw material. Some of this is the information on which the analyst can make interpretations. This is the information on which the analyst can communicate emotionally, or at least part of it. You do need words to help understand the patient. But I'm talking about something a little bit different here. I'm talking about what happens when the patient puts their own thoughts and feelings into words, as opposed to getting a feeling from the analyst or getting information from the analyst. So Freud also said that the condition under which material from the id can become part of the ego is when it is put into words. Spotnitz later said, in an idea that seemed initially very strange to me, but once you think about it, I think it's obviously true, that when somebody puts something into words, you are creating new neural pathways of discharge that don't exist when the patient is simply thinking. And I think almost everyone has the experience of having thoughts and having feelings, and they seem really, really clear. But once you start talking, they're different. They're not the same. And all the more so with writing. People who aren't natural writers always think, well, I've got all these thoughts in my head. Why can't I write them? You haven't created the pathways within your mind to take those jumbled thoughts, which seem like they're in language, but they're not really, or you'd be able to do it. So when you put things in language, you're certainly activating a different part of your brain. You're certainly activating Broca's region, for instance, over there on the left and the middle on the side, sort of. Something is operating differently than either when you're understanding or when you're feeling. And that as you do that, many people find that they feel stronger, they feel more in control, they may have insight. So for instance, you keep talking and you hear things that you didn't hear before you started talking. So many things become obvious once you start talking that weren't obvious at all. Okay. On the other hand, but that's a secondary quality to it. You may end up having feelings that you didn't have before. You may start talking and feelings start brewing up and you have a different affective experience. So that brings you in touch with parts of your mind that you were not in touch with before. But all of that may be secondary to the whole experience of owning more of your experience by putting it into words. Now, now the counterpoint. Does that mean that everything must be verbalized? Absolutely not. We have all had the experience, I'm sure, either with ourselves or a patient, where you make an interpretation, it goes in, and the person just thinks, or you just think, and you feel the reverberation, or you feel that self-control, or you feel whatever you feel, and you don't need to put it into words. It's curative. It helped. Same thing with an emotional communication. Some of these things happen and nothing gets said afterward. Nothing gets put into words afterward. It's very easy when you are concerned about doing it right, being caught by the analytic police, making sure that you're covering all of your bases, to then try to have the patient put it into words. But think of how many human experiences take place wordlessly. For many people, great sex takes place wordlessly. That doesn't mean that you can't have great sex and talk. I'm saying that you can have it. Think of art when you see a painting or you hear a piece of music. Music is an even better example. Think of all the ways that music acts on you emotionally, and you couldn't possibly put it into words. So putting it into words is a powerful curative experience, but it is not the only one. These other two are equally important. I think to the extent that you can say to yourself, all of these experiences can contribute. Each patient will respond differently. You know, I am better at one than the other. Okay, that's more than fair. You may be better at interpretations. You know, I knew of one analyst, this was a particularly striking case. I separately ran into 3 of his patients. They all hated him. I mean, they said he was gauche, he was insensitive, he stunk. I mean, there was nothing they liked about him. His interpretations were so helpful. They say, I can't stand him, but he tells me things about myself and they always help me. And I don't think it was that it was valuable for them to hate him. I think they genuinely appreciated the interpretation, even though he was an unpleasant, odious character. Okay? So you can get things out of interpretation without the other experiences. Okay? And they aren't necessarily interchangeable. They can be combined, but you don't need to force the patient's emotional river by forcing them in one direction rather than the other. Now, it's very tempting to then try to say, as we should try to say, I think, which patients will be helped by one rather than the other. So this is where, going back to Eisler, okay, Eisler said, you know, if the patient can respond to an interpretation, then they're neurotic, then they're analyzable. And as for everyone else, they need parameters, okay? They're not there, okay? Spotnitz, who was writing at the same time as Eisler, actually came up with something remarkably similar, only far more inclusive, which is, he said, if a patient is pre-Oedipal, if their problems come from the period before they've had words, if they are dealing with the earliest experiences, that interpretations won't work, you have to use emotional communication. But at the same time, Melanie Klein was working with those patients and using interpretation. It's a tempting thought to say that some kinds of developmental issues, some kinds of diagnoses respond to one of these experiences more than the other. My own experience is it is completely random. I have had schizophrenic patients who respond beautifully to interpretations. I've had people who look like they're complete neurotics, who are, analysts who, seem like they would benefit from insight, and they get nothing whatsoever from it. Okay. And at different points in time, people will respond to different things. There's a sense in almost every school of thought that we have a goal that we're aiming for. Spotnitz would like you to say that you can, when you can feel all of your feelings and you can put all of your thoughts and feelings into words, you're cured. Well, I don't know. There's going to be a lot of stuff that people will never be able to put into words. There's a lot of feelings that aren't going to help people. There's a limit to all of that. I think what you need to do is one therapeutic moment at a time, which will stretch out, obviously. I don't mean minute to minute usually. When it's minute to minute, it's exhausting. When somebody needs to move back and forth between words and interpretation and feelings, it's exhilarating, but it's absolutely exhausting if you can't keep up with it. But usually there'll be periods where one particular mode seems to work better, or where you find that a patient does very well with interpretations as long as they've got a relatively cool emotional communication. You're not allowed to be too interested in them. Somebody else could respond to the same interpretations, but you have to be much warmer. You can blend all of these things. Some people do great when they've had one of those silent, spectacular moments, and then you say, can you tell me what happened? And somebody else, you say, can you tell me what happened? And they say, you're wrecking it. It was beautiful just the way it is. Don't gild the lily. No, I don't want to talk about it. So are there other experiences? Are there other therapeutic experiences? Probably. But as I've looked at my work and other people's work, these three tend to stand out. And my goal in all of this is let your technique be free. Use these kinds of guidelines to give you more freedom to work, but not less freedom. Okay. If you're doing something that doesn't fit into one of these categories, don't worry about it. That's not the point. The point is find what seems to work with that particular patient and keep using that regardless of whether or not it fits the theory or anything else, and expand your theory in this way only to help more patients, not to have the patient fit the theory of cure. Okay. And those are my thoughts on this. I would be happy to hear. We can open it up. And okay, I'm going to try calling on people isn't always going to work here. Let's see. William, why don't you go for William
Alexi?
Yeah, Alexi. Yeah.
Yeah. Thank you, Paul.
Yeah.
And thank you for what you've been sharing with us so far. What occurs to me is that with each of these forms of curative interventions, that they're volitional. In other words, the analyst decides, chooses. This is what I think is best. This is what seems to be called for now. And I get that, and I see its value. My experience also is that so much of what is going on between patient and analyst is at an unconscious level. So it's not volitional. For example, I may recognize that I'm having a particular reverie at a particular point in time with the patient, and that affective resonance gets conveyed to the patient and has hopefully a curative or healing effect without volition being involved. So could you speak to what it is I'm bringing to your attention?
Well, Okay, that's a very important point. It's very difficult to talk about technique outside of a volitional context, even though probably 85% of what happens with most sessions is not volitional.
Right.
Okay. Nevertheless, your training, your thoughts, all of those things are going into how you're actually communicating to the patient. And as long as things seem to be rolling, and that would require another more detailed discussion about what constitutes progress, how do we decide whether or not, things are rolling along. But let's, for this purpose, say things are rolling along. You don't need to interrogate it, okay? You don't need to go volitional, and you don't really need to analyze it. It's a little bit like when you're riding a bicycle. You really can't think about every single thing that you're doing, or you're not going to be able to stay up. But when you hit a bump, or when something strange is happening, you may need to think about it more. So it's more when things get really, really stuck, or when you're getting really unexpected responses, when you see the patient shutting down, when they're starting to deaden, when they're getting irritated in a way that does not feel progressive. And again, it's hard to say all of the things that would go into that quickly. Then any kind of technical framework gives you a compass to say what might be going wrong. Okay. Am I asking for too much verbalization? Am I providing too much feeling? Am I trying to get them to understand something and I should shift gears? But the moment that you're describing, when you're in a reverie and there's a resonance and they seem to be working, and the two of you are like playing a duet together, then no, you don't want to interrupt it with volition in the same way that you would not want everything put into words all the time. But, when things are going great, that's great. It's when they're not going great that you go back to this kind of thing. Or you think about it and you find yourself not stretching, because I don't really feel like analysts should stretch, but you do find yourself doing new things that allow in new experiences.
Yeah, thank you.
Okay. Yeah. Let's see. Candace? Yeah.
Hi, yeah. In terms of using emotional communication, now I think you said you start with an emotion that you're having. How do you know, what if the client isn't asking questions about you? How do you know when they're ready to have you say?
Okay, now that's a good question, because the example I gave was when it was a very specific moment. The patient was asking for contact.
Right.
Okay. So let's use an absolutely banal example. Okay, that the patient is complaining about something that happens at work, and my feeling is they're being very polite about it. Okay, they have not contacted me. They haven't asked me anything. Okay, so they're complaining about their boss and they're attacking themselves at the same time. And you have the feeling that they're really much angrier or upset than they're letting on. So you want to help them to have that feeling, okay? For whatever reason, but that's something we're often going to want to do. If we see that there's a feeling and we see that there's a defense, that's usually a good place to be thinking about. So they say that, and you, instead of just listening, they're saying, well, it was, I don't know. And then I had to stay a little later and he was mean. So I'm not saying that sucks, that bastard, Now, again, I'm painting in broad strokes there. If the patient is very, very defended against the feeling, then I would up it just a little bit. Well, that's kind of annoying, or that might be annoying, or I might be annoyed. Okay. How you place the feeling? Do you own it? Do you generalize it to the universal you? Do you just kind of make it come from the universe, or do you personalize it? Those are all very specific decisions. But in all cases, you may come right in with the feeling to either amplify it, to agree with it, to give voice to it. Okay. And, emotional communication is very complicated. the feeling that you're having may not be the feeling that you want to communicate. Okay, if you're having the feeling that the patient is droning on, and if they keep talking like that, you feel like you're going to be suffocated. There are analysts who would communicate that feeling. I would do it very, very, very rarely, only under very specific circumstances. Most of the time, and again, I'm generalizing outrageously here, I'm going to be containing that feeling. I'm not, the emotional communication is that I don't express that feeling. Okay, so which feeling you communicate is more complicated, but okay. You're muted. I'm sorry, Candace. Yeah. I don't know what happened here.
All right, so that's a great example, because I have a lot of clients that will, start talking about something that they can't stand that their boss did, and then immediately start berating themselves. So it's a good example, and it's something I could,
Yeah,
experiment with quickly.
yeah, and it reminds me of something else, okay, which I didn't say, which is very important. Okay, all of these experiences can happen outside of analysis. Okay, you can read an interpretation in books. Okay, people can explain things to you. You can go to a meeting and hear people say stuff. Okay, emotional communication starts, in utero, and it ends at death, as far as I can tell. I don't know whether there's anything after that, but it's always there. Talking happens all the time. So nothing about these experiences themselves are unique to analysis, except that we want to have that when you provide these experiences in the context of a transference, then you're doing analysis. So let's take your example, the example there that I just gave, where I would say that sucks. Okay. I'm going to do that under a particular transference configuration. The transference configuration is the patient is experiencing me as being more or less like them, a narcissistic transference, and I'm thinking that I feel more or less like them. And because they and I are similar, they can hear things from me that they can't say to themselves. Okay, we're using our sameness as a basis for communicating a feeling that they might then be able to own. That's the underlying theory with that technique, but it is based on a sense about the transference. Okay? The transference is what takes us to the repetitions. Okay, the transference is what makes everything we do rooted in the patient's past and not just a conversation between two people about people's problems in the present.
Right.
So all of these things, the interpretations are not necessarily interpretations about the transference, but they are interpretations that the patient will experience in terms of the transference. Okay, and the same verbalization is probably the least transference oriented of them. But that is the secret sauce in analysis. Understanding the patient in terms of the transference, which is whatever repetition is active toward you in the analysis at that point in time. It doesn't mean you're talking about it, but it means you're thinking about it.
Right.
And most analysts almost automatically start doing this. They work in terms of the transference even when they can't articulate the transference. Whereas to contrast that with the absolute opposite type of treatment, a manualized psychotherapy, then you're reading from a book, everybody gets the same thing, and your interventions are not adjusted to the transference. It may work. I'm not saying it's bad. I'm just saying it's not analysis. It's entirely different. It's that focus that makes analysis different than emotional communication and teaching in any other area. Okay.
Yeah, great. Thank you.
Other questions or thoughts or anything? Okay.
Well, I have one more,
Hi,
but
Paul, it's Adam.
oh,
Oh, hi. Oh, okay. Adam. Oh, I'm sorry. I didn't. Okay. Yeah. Let's do Adam
I'm
now.
on my
Okay.
wife's.
Yes,
on
I
my
see.
wife's Zoom, so it's
But I see
I
you.
get to
I don't
see you.
see her
Thank
right
you.
now. I see the baby, right? Okay.
yeah,
Yeah.
the baby's in my
Okay.
arms.
Okay.
Say hi, Chloe. She's sleeping.
Okay.
So, great talk. Thank you. Really enjoying it. Where do you see symbolic communication as it being in relation to emotional communication? Where the
Oh, God, you know what? I'm not surprised. Now, Adam, by the way, is a brilliant poet, and I'm not surprised you have that question. And now that's an interesting thought, because I was thinking before the talk, well, what about art? What about symbolism? I'm inclined to, I would say that symbolic communications can either be more, well, I don't know. What do you think? A separate category, or something that's an amalgam of interpretation and emotion?
I think, yeah, I guess it's a question because it's an image, or I know a big modern analytic symbolic communication. You have a patient patients that talk about how they're hungry, to ask the question, should I be serving food here, for instance, or what kind of food? And one starts to get into a conversation, and there's hunger and feelings of nerve. It seems to touch in on all the points.
Okay, so on that level, okay, let's take that one. Let's take the patient comes in and they say that they're hungry. Okay, so if you're asking questions about it, if you're exploring, then you're encouraging verbalization. Okay, if you give the patient a sandwich, you're engaging in emotional communication. If you tell the patient how to cook a restaurant to go after, you're using emotional communication. So if you're telling the patient that I really wish I could feed you, you're engaging in emotional communication. To the extent that you are saying, what should I give you? What would that be like? Then you're helping the patient put their experience into words. Now, that's a good question, because that's a line in the sand for a lot of analysts. You will ask them what you want to cook them. Some analysts will then say, well, I'd really like to cook that for you. And then some might, if they have any food, offer them some food. Those are two different lines there, right? A lot of analysts would draw the line at exploration. And then they're working with verbalization. And then they might move into an interpretation. Well, if I was a better analyst, would I be feeding you? I have the impression that when somebody feeds you, then you are feeling understood and cared for. So you're moving between different modes there. But once you say, I'd really like to make a hamburger for you, or I'd like to make my special saffron fish sauce for you, then you're in the realm of emotional communication.
So do you think it's unnecessary hair splitting to even separate emotional and symbolic? Because if you start talking about the actual sauce, you could say that it's a symbol of milk or some kind.
It's a symbol, but it's conveying it's a symbol, but it's conveying a feeling. Okay. What isn't hair splitting is whether or not you talk about what you're going to do. That's a real hard line in technique. It doesn't mean that you can't do both, but it does mean that where you're willing to go and how you're willing to work is different. Once you're communicating a feeling explicitly, you're using a particular experience. They may combine things. I'm not saying that it's not going to combine, but many analysts would not do that. I'm not saying that's good or bad. I'm just saying that's where that is a line for them. And it is based on a different type of experience, I think. I think I've said that twice already, so I don't want to belabor it.
Got it. Thank you.
Okay.
Thanks.
Anyone else?
Well, I have a question.
Yeah.
Is it okay to go ahead?
I'm sorry. Let me do Angela first, and then we'll do you,
Sure.
Nicole.
Sure, sure.
It's hard to keep track of everyone.
Yeah,
Angela?
Yeah, I just wanted, thank you. I just wanted clarification when you said, when you get to the point where you'd like to say, I'd really like to make you my favorite fish sauce, that is the realm of emotional communication. Is that what you said?
I would say yes.
Okay.
Okay,
All
at
right.
some point, we are splitting hairs, but what? it
That's
seems
okay. Yeah, I just want to make sure I heard it right.
Okay,
Yeah.
was that all? Yeah.
Yep.
Okay, Nicole? Yeah.
It's a question about disclosure, which is, I know kind of more the territory of relational analysts, but I guess in a lot of the examples you've given of emotional communication, what you're also doing is making a disclosure about, I don't know, like your favorite hamburger recipe, or, you know what I mean? There are levels of disclosure in that. And I just wondered, the question is not very clearly formulated, but I wonder about that. Like, I mean, to what extent are you disclosing a fact about your life, and to what extent is that compromising? I mean, can you separate the emotional communication from the disclosure?
No, I think your question is clear. It's a good question, and I'm very opinionated about it. So if anyone disagrees, feel free, but I'm very ornery about this, okay? So
Great.
my feeling, okay, by and large, and I'm oversimplifying, in the relational school, there's a tendency that when disclosures are made, it's because there is some sense that the patient needs to know the analyst's subjectivity.
Yeah.
When I'm making a disclosure, I'm making it because I think the patient needs a very specific aspect of my subjectivity, not me in general, but an aspect of my emotional life that's going to be beneficial to them at a particular point in time. Now, from a classical point of view, you are definitely compromising things, and one can say that you're distorting the transference by introducing reality. So what that kind of technique is not really compatible with the notion that you should not disclose, that you should not compromise the transference in that way. My own experience has been that you get a lot more traction by doing that, and that it is actually very difficult to really distort a transference with facts from the analyst's life. That said, I probably use that particular type of emotional communication more than even many modern analysts. So I'm a little bit of an outlier in that way, because I think that in terms of helping certain kinds of meeting developmental narcissistic needs and analytic needs, narcissistic needs being those that are related to needing a similar object to themselves, and analytic needs being those related to dependency, that when you use yourself in that way, I tend to get better results. So I'm less concerned about my analytic blank screenism, okay? I understand the reason for that approach, but it's not one that I found to be as helpful as this other way. Does that address your question?
Yeah, I mean, I guess, yeah, definitely. The question that comes to mind, or the example that comes to mind, is one you used. I think you were talking about Tom Cruise or something. Like, what, in that example, does it? If the function of the emotional communication is to allow the patient to see that it's like totally fine to hate Tom Cruise or think he's a narcissistic prick or whatever, but you happen to like him, what I wasn't clear about is if there have,
I wouldn't use a feeling. I wouldn't fake.
There
are
you wouldn't
moments
fake it,
where
right.
I would fake a feeling. Okay,
Right.
I'm not saying I'm never going to do it.
Right.
And I kind of don't want to. Those are a little too complicated, and I wouldn't want to get into that now. But something like that, I wouldn't do. I would wait for a moment where I do agree with them. And the fact of the matter is that under the influence of transference and countertransference, even if you like Tom Cruise, you might feel that way in the moment. I will never forget the moment that in the election night when Bush was beating Gore, and I have a patient on the couch and he's saying, God, I hope Bush wins. And I'm thinking, oh, I hope Bush wins. And then I said to myself, oh my fucking God, what did I just say to myself? I don't hope Bush wins. But under the influence of narcissistic transference and countertransference, you can wish all kinds of things because your emotional life at that point is induced by them and you are borrowing their feelings.
Right.
So now that said, sometimes you will say something about yourself that does compromise things, that seriously disrupts the patient. And that can happen even if you don't disclose things about yourself intentionally, but when you do, there's a higher risk of that. And then you have to deal with that. It is not a risk-free intervention. I do want to be clear about that. It isn't as if you can say anything you want and you will never have any problems. I'm talking about things globally here. All of the almost all of the emotional communications carry a somewhat higher risk. Well, some carry some risk, but interpretations carry risk too. They can disrupt defenses, people can feel misunderstood, they can feel attacked. You know, somebody once said that the intervention that carries the least risk is the Rogerian reflection. So the patient says, I'm really cold, and you say, you're really cold. You know, and a lot of people find that really helpful, by the way, but it's probably the lowest risk intervention. I've said things that I think are such milquetoast, empathic, sympathetic comments to people that I didn't know how anyone could be upset by it, and they felt radically misunderstood. So none of this has to do with the risk level, okay?
Yeah.
Oh, Paul, this is Antoinette calling.
Oh, hi,
Hello?
Antoinette. Hi, yeah.
Oh, yeah, hi. I just want to say is that I really like when you said, well, these weren't your exact words, but really it's like one size doesn't fit all, and that to take one, like one therapeutic moment at a time, because what works for some patients really don't work for others. So, so I'm just happy that that was acknowledged, because sometimes I could try the same thing with another patient and it didn't work. So,
Yeah.
So anyway, that being said.
Thank you. Thank you. Yeah. Let's see. Anyone? Okay, if that's the case, if everyone is okay and no further questions or comments. Now, I was able to set this up so that I can give CEUs for social workers and licensed psychoanalysts. If you want that, go to the website and click the window that says certificate. I will send out an email afterward, and I hope I can send it out today and remember, okay? But just try to keep this in mind. If you want that, there's a password that's testing 123. That's the password. And then you can fill out the information. There's a $20 charge through PayPal. And then the certificate will be mailed to you. And if you don't get it emailed to you. So if you don't get it, give me about 10 days or 2 weeks. If you don't get it, I promise you'll get it. Oh, you have to fill out the course evaluation form. Okay, the whole thing takes about 5 minutes. Okay, so it's worth an hour and a half of CEUs. Unfortunately, not yet for psychologists, but I'm working on that. Okay.
How about New Jersey?
Well, it'll be New York, but most of these states accept something from another state. Okay, so you know.
Thank you, Paul. This was great. Thanks a lot.
Oh, thank you. Thank
It
you.
was wonderful. It was really helpful and wonderful.
Beautiful.
I really,
Yes, I agree.
appreciate
Very
you all
great.
coming out on a beautiful, staying in on a beautiful day here.
Right.
And there's a bunch of people here. People I haven't seen in years, some colleagues I haven't seen in years, new people. Yes, thank you. And
Thank you, Paul.
Really great. Thank you. Awesome.
Okay. Terrific.
Thanks, Paul.
Okay, I will keep you
Thank you so
posted
much.
if I do anything else.
Right.
If you have any other, this will be recorded. It'll get up on my website at some point soon. Okay,
Great.
as long as the recording
Awesome.
works.
Fun.
Okay. Be well, everyone, and thank you so much.
Thank you. Bye.
Bye-bye.
Take care. Have a great
Thank you.
weekend.
Bye.
Good to
Thank
see
you.
you.
See you.